So good afternoon, everybody. Thank you for joining us for this lecture today. My name is Bob Fisher. I graduated in 1970 from the School of Engineering, and I'm proud to say that I have two sons who also graduated from Johns Hopkins. Thank you. As a Hopkins alum, I'm always proud to see Hopkins and the Hopkins community in the press for everything that they do. I think it's amazing. But my pride for the school has really jumped up a notch as I've seen the school become a leader in tracking the virus through the COVID-19 map and dashboard. And it gives me great pleasure to have the opportunity to introduce the creator of this map, Dr. Lauren Gardner. Dr. Gardner is the Alton and Sarah Cleveland Professor in the Department of Civil and Systems Engineering at the Whiting School of Engineering and has a joint appointment in the Bloomberg School of Public Health. The dashboard has been cited in multiple medias around the world and through the country, Wall Street Journal, CNN, just to name a couple. Dr. Gardner was named one of Time's 100 most influential people in 2020 for her work in filling the void of the public health leadership during the pandemic. Her work focuses holistically on virus diffusion as a function of climate, land use, human behavior, mobility, and other contributing risk factors. She received her bachelor degree in architectural engineering, her master's degree in civil engineering, and her PhD in transportation engineering at the University of Texas in Austin. And it gives me great pleasure to introduce Dr. Gardner.
All right, thank you very much. So I'm here to talk to everybody about the one thing that we haven't obviously been talking enough about over the last 2 years. So more about COVID. But yeah, so as Bob mentioned, I am responsible partially for this map that you've probably seen more than you would like to have seen as well over the last couple of years. And so since January of 2020, I've been leading the efforts behind this visualization and the data collection supporting it. Planning to talk through today is a bit about why we started this, the evolution of it, which is pretty dramatic compared to where it started and where we are now. But then I'm an engineering professor and I work with a bunch of PhD students that like to use data and use math to actually help solve problems and provide decision support for all sorts of policies around mitigating these kind of risks. And so I think I will have time as well to talk a bit about how in our group we've been using the data as well, in addition to just collecting it, because I think that's really where we serve a core purpose as a research team. And so I'm really happy also to make this flexible and interactive. So please feel free to ask questions throughout. I think we do have a time for a Q&A afterwards, but feel free to yell out or interrupt if there's anything I'm talking about that you want to hear a little bit more about or don't understand. And also, before I get started, I just want to highlight, and I think this is something that's really, really cool, is that this work actually comes out of engineering. Almost everybody that's been involved with the dashboard efforts is actually not a public health trained professional. It's a group of technical people that sit across engineering and computer science and software designers and software developers and data scientists. So it's been a really unique opportunity to get to be a group of scientists that are having such an impact in a field that isn't one that we were classically trained in. And so this work started out of the Center for Systems Science Engineering, which is a center that I direct that's home based in CASE, which is the Civil and Systems Engineering Department. Just right now, we're actually in the process of rebranding ourselves and kind of formalizing this role of systems in engineering. And I think that the work that we've been doing with COVID really highlights that that's the right thing to be going about right now in terms of civil engineering really being this kind of more societal engineering field that can touch and address and impact all sorts of different problems outside of what it traditionally is thought of as contributing to. And so just this is a bit about us, some of the first members from when I came a few years ago. And really we work on a broad span of things, from energy, health, transportation, now also space. So separate from what we're going to talk about today, if anyone is just curious or interested in what we're doing in the Civil and Systems Engineering Department, I'd be happy to chat on that as well. It's a really great group that are doing all sorts of really interesting kind of non-traditional civil engineering research and applications. So back to COVID. This is the map that we created. What we're doing is we're collecting information on official COVID cases, deaths, and now vaccinations for anywhere in the world that officially reports them. And so all in all, we're collecting over 10,000 points an hour of data, because we have data that's collected at different spatial scales. So for the US, we collect data at the county level. For a lot of countries around the world, we collect it at subnational level, so state or province, and quite a few we still collect at the country level. And so across all of these, it's about 4,000 point locations. We're collecting case data, death data, vaccination data, actually lots of other data as well, in terms of testing, types of vaccines, breakdowns on some of these variables. But specifically for this global mapping effort, that works out to be about 10,000 variables that we pull every hour and process through this infrastructure that we've built from scratch to populate this dashboard, and also populate the open data product that goes alongside of it that's used. And that is what you see referenced all the time in the media. In addition to the big red dots in the maps that everyone's familiar with, which was originally tracking, ideally this real-time risk so that we're all aware of what's going on. We also have lots of other layers on the map that normalize the data we collect to populations, because the original intention of this was to have an understanding of the relative impact of COVID and the relative harm, and with vaccines, the relative equity in terms of their distributions and uptake around the world. And so most people just pay attention to the big red dots, which is cumulative cases to date. The default map you see now is actually cases in the last 28 days, because what's happening now is not necessarily exactly correlated to what has happened over the whole 2-year period that we've been experiencing. And then there's the other layers that look at how other variables we're interested in are also tracking. So that's what exists, or part of it. But I wanted to start with talking about why we did this. So I'm in engineering. All my degrees are engineering, but since my PhD, I've been working in this intersection of engineering and public health, and really interested in using math, modeling, and data to understand infectious disease risk, and in particular, focused on emerging infectious diseases. So these are diseases, new novel pathogens that we don't know a lot about. There's a lot of uncertainty. We don't know what impact they're going to have, how they're going to spread. And to answer these questions, we need good quality, accessible, accurate, timely data. And so this is a known gap that exists in this discipline. And so when what wasn't called COVID at the time started, I had kind of this knowledge and this interest aligned with a new PhD student in Shandong, who is from China and was very personally interested in these new cases of novel pneumonia that were popping up in China and being talked about by his friends and family. So he was following the data on some Chinese websites that were reporting the cases. There was a few hundred at a time from a few different cities there. And we were watching it in just kind of a spreadsheet, and decided during a lab meeting one day in January, when we were talking about all the other projects that were really important that we were doing, that we basically had to put aside for 2 years, that we would continue to build out this dynamic data set, but critically that we would share it so that anyone else that might be interested in answering questions like we were would have access to it. And that we would also build a map to look at the data as we were tracking it because it's such a natural way to visualize spatial epidemiology. So that night we built this dashboard, the prototype of it, and put all of the data into a Google Sheets doc. And then I tweeted it the next morning to share it and let my small research community know that we would be collecting this information and it would be available for use for anyone that wanted it. At that time, in that first couple of weeks of January, we were actually more interested in using the data for modeling than we were on collecting the data. It was just a necessary evil. And so we were trying to look at things like mapping, given where COVID is reported now, where we thought it would spread globally, how many cases we thought there really were versus how many were being reported. And so this is work we were doing in the first couple of weeks of January of 2020 and sharing this data and circulating it, with CDC colleagues and other research groups. So that was January. And again, the underlying philosophy of all of this was open data, open science. So we did everything with the intention of it always being available for use. And so it was in Google Sheets for a whole few days and then moved to a GitHub repo because it was growing fast and that was necessary. All the mapping layers that we've built have been available as a feature service on ArcGIS. So anyone can pull the data, the maps, and use them and visualize them themselves in other GIS software platforms. And the data is sat under an attribution, international attribution license as well, so anyone can use it. So the initial stages for this data collection were very simple because they had to be. And I just want to remind everyone, this was a time when there was not a COVID dedicated web page by a public health institute anywhere in the world. So there weren't just web pages to scrape case data from, which is what exists now. The cases were being reported in these kind of one-off, non-traditional sources by news articles, blogs, and tweets by public health institutes around the world. And so we were having to kind of manually collect this data that we were informed on through crowdsourcing or that we were finding ourselves and validate every single data point and then manually put it into the data, Google Sheets to start with and using it to populate the map as well. So it was a very manual intensive effort. That is something that worked fine for the scale of the outbreak at the time, but obviously did not scale with the exponential growth of the outbreak. So we're doing this, and at the same time, we all know what happened. COVID took off, and the interest in it also appropriately grew exponentially. So we went from having this data available and shared a few hundred times to getting over 1 million hits in just a week after we had made it public. And it was getting immediately relied upon by media all over the world and being referenced for tracking. And I think what was really critical here is we were tracking COVID as it was spreading and being reported in new countries and making that public in this very accessible and intuitive form and beating organizations like the WHO on making that information public in their regular summary reports. So it was really about the timeliness of it that was critical at this period. But given this growth and this exposure and the scale of everything that was going on, we knew we really needed to re-strategize on how we would go about this because we were now committed to it. And so we partnered up with some amazing groups. On one hand, we partnered with Esri, who is the software, who hosts the software that we were using for the mapping. And then across the university as well. So we started working closely with the Applied Physics Laboratory, who were helping us to build out this much more robust and resilient data collection scraping infrastructure. Also with the libraries team to help host it. And then this is something that we obviously grew in my group and in engineering and has been substantially supported by the university from the start. And this is something that I personally get way more credit for than I deserve. This group, which is really the initial group across APL, Esri, and my team, have been so committed to it from the start. and have not slept nearly as much as they should have for the last 2 years because of it, and deserve more credit than I should ever get for making sure that this thing has actually been maintained and that the quality has stayed superb over time. So as this need was growing, we knew that we really needed to re-strategize and rethink how we were going to go about doing this. And so I'm not going to be able to go through all the stages of the architecture of this data collection, but I think I want to hit on just a couple of the major intersection points. And the first thing that we did in terms of moving forward was expanding two pieces of it. One of them, as the outbreak was growing, we needed to expand where we were sourcing data from. So it was affecting more locations, more countries, more cities, and this data was now starting to become more readily available in more authoritative formats by these different locations. And so our focus has always been prioritizing and validating the most reliable sources. And so we spent a lot of effort, and still do, growing our set of sources where we collect data from. And then at the same time, we needed to automate this data collection. We could not do this manually. There still are pieces that are manual because they have to be, because of how data is reported. However, the effort was really about trying to automate as much of it as possible. So this effort focused on that. We started building this out. And then this data is pulled together from these sources and sent through into a somewhat more automated pipeline that's then sent through into a GitHub repository, where it lives and is pulled directly from a lot of people that rely on it, from all the CNNs and NPRs and all of the modeling teams and CDC and the groups that rely on the data directly. But it's also used, the GitHub is used as a mechanism to populate and propagate the data through directly to our dashboard, and also lots of others, emergency response groups that pull the data out of there for visualization purposes. So we're building this plane while flying it in a lightning storm. It's a total disaster. And we've now gone from, hundreds to thousands to millions to billions of hits a day on this dashboard. And there was always some really interesting behavior too that we could watch as this was happening, because we would see these massive spikes in usership as the pandemic would move into new regions of the world. And we would see this huge new demand when it would get to Europe, and when there was the first outbreaks in Italy. And similarly, when it came over to the US, there was this big spike in the early spring. There was all sorts of interesting and fun takeaways that I would get in terms of which countries were particularly picky about making sure that we had data in a very timely manner. Some in particular would be really good at letting us know that a new case had been reported within the hour. Some were a little bit more low-key about it, we'll say. So we were building out this infrastructure from scratch when this usership was happening and when the outbreak was growing in scale the way it was. So it was a huge challenge. It still is, but this first 6 months was really very chaotic. And this usership was coming from everywhere. And I think that this has been one of the most exciting but biggest surprises and takeaways for me in terms of when we started this, who I intended the users to be versus who ended up being the dominant user group. And we found that this served public good and served individuals more than anything else, which is not something that's usually an opportunity for scientists and researchers, I think. So it really went viral on all of the social media platforms, and that was what was driving the demand. But then at the same time, it was being relied upon by our, highest heads of states for making decisions, which really highlighted this surprising gap in this kind of information being available to the people that really needed it, that you would rely upon for decision making. So I love the photo of our dashboard photobombing Mike Pence at the HHR Operations Center. And at the same time that this was kind of growing in this public domain and obviously in this government domain, it was obviously also being relied upon by most mainstream media around the world. And so this was great, but provided a lot of challenges. It also created a lot of challenges. So it provided a lot of opportunity, but created a lot of challenges. And there was so many types of issues that we had to deal with that I just never expected would be part of my day. As an engineering professor. And we had everything from trying to deal with geopolitical issues and disputed territorial boundaries to choosing appropriate naming conventions, given we're dealing with a pandemic and not everyone in the world agrees on what countries should be called. We had this was obviously a very politicized public health crisis, and we were at points criticized and falsely accused, obviously, of putting our data up behind paywalls by our administration when we were having technical difficulties. So I spent a lot of 2020 doing communications. And I think that one of the biggest things I've learned over this last couple of years that I always valued and knew was important, but I didn't realize what was required to do it well, is the role of science communication and science translation. And I spent more hours communicating on what we were doing and how we were doing it than I did on actually doing it, which was a real surprise, and still do. And I talk to journalists all the time, still trying to help them explain to the public how things are done, should be done, what's missing. And so it's been a really unique opportunity actually to be a voice in this space. And I think that I really hope that that plays a bigger role, not just in public health, but in all sorts of things where we would really do well to have, more facts and evidence-based knowledge and information coming out of researchers and institutions and places where it should come from, and that being relied upon and communicated directly to the public. So again, we kind of grew our team. And one of the things we did in spring of 2020 is kind of grow the global dashboard into the Coronavirus Resource Center, which Hopkins hosts. And that expanded. It was originally built around this mapping effort, but there was just so much more of a story to tell. And so that really took the role of contextualizing the data. So we have this data and we can see it, but there's so much more to it. And that was a collaboration that was really led and jointly led by the Center for Civic Impact, which is led by Beth Blauer, who is probably my closest collaborator at the moment and has been over the last couple of years because of this. And so that effort kind of took this much more robust data collection infrastructure that we have. We now have data that we're collecting from hundreds of different sources and websites around the world that have customized scrapers for each one of them because they have to, because the data is provided in a very non-standardized format. And it's independently collected by all these autonomous collection agents, pulled together and gotten through this comprehensive data curation pipeline that we've built with things that we built from scratch, like anomaly detection systems, so that we can deal with errors that would potentially propagate from the source all the way through to the map, deal with how to fuse data sets because there's inconsistencies in what's collected, and all sorts of issues in terms of the structure of the data and the quality of the data and biases in the data that we try our best to address as we're pulling it through. It is far from perfect. It's still very much in development, but it helps. And it's still also codependent on a lot of humans because a lot of the data just isn't available in a way that we can automate everything. And we have human checks in place all the time. So when we find what we think is going to be an anomaly, we hold it back and we have a human check it and validate it before we let it show up on the map. Things we learned the hard way. And so we have this system in place, and then all of this data goes into the global map, into the GitHub, and then onto the Coronavirus Resource Center, where it's combined with multiple other different types of contextual variables that tell the story about things like well, what's happening with COVID here? And then what does this population look like? And trying to better understand all the discrepancies and inequities and other issues that we know exist that have really been highlighted by COVID. So this has another big US focus, but outside of just that, it also uses expertise we have across this university to dig into things from not only tracking, but also understanding contact tracing and vaccinations and testing and all sorts of different issues that have come up around COVID. And then this has been a real place also for advocacy around how public health policy making should be done, how data should be collected. And so if you haven't ever looked at it, there's a gold mine of really useful information and also lots of, we'll say, suggestions for how we could potentially improve these systems that are currently in place for the future. So the data in the end has been used in so many different ways, and I think it's really served a lot of public good. And this is just as rewarding of an experience, I think, as you can have as a human, but also obviously as a researcher and an academic and a scientist and all of these things. So as expected, or as hoped, I guess, to start with, it's been used by research groups and by public health policymakers to actually make decisions. And so, you know, on the left, we have how it actually serves as both the ground truth, but then also used to train and validate the models that go into all the CDC forecasting efforts and ensemble methods and looking at those scenarios. And this is an example where my group is actually one of the teams that does build out these forecasting models and contribute those. So we collect the data, but we also use it. And that makes us very keenly aware of the challenges of it and the data quality issues. And so we're a real connection between the data collection and then the modeling efforts that rely on it, and work really closely with both teams to try and make it as valuable of a resource as possible for these kind of needs. It's pulled and used through mainstream media and mainstream media to obviously communicate and inform public. But then I think most critically, it's just been democratized and is directly available to everyone, to the public, to every individual, to see themselves. And they can pull the raw data and they can analyze it and they can do whatever they want. But it's also been directly integrated into things like Google Maps. So it's just there used to help inform people about risk. And I think that given how politicized COVID has been, this is so valuable because we've been through these environments where often you have policy that is either non-existent or very lagging in terms of its actual value and impact. And so when these things didn't exist in particular locations, that information was still available. The science, the facts, the information was still available for people to make their own informed decisions and hopefully protect themselves. I can say all of this because I'm from Texas. And so I can just say that it is a different country than Maryland. And as someone that has gone back and forth a couple times during the pandemic, the first times I was shocked because I got there and I was like, oh, who knew? There was no pandemic in Texas. Nobody has to wear a mask. Everyone just has a gun instead because I guess they can shoot COVID. I'm not really sure. But it's, I think, really just making this kind of information available so that people can make decisions when there's not someone making them for them or helping to protect them is really some of the most value that it served. And then it's obviously, as a researcher, and it's really exciting to me that it is relied upon so heavily by my research community. And it is used in most of the work that people are doing in terms of trying to prospectively and retrospectively understand COVID better. I don't know how I'm doing on time. Okay, just keep talking. You guys just tell me. But I think that a couple of the important things. So one of the things is, it's probably obvious to everyone that this was really challenging, but if it wasn't, then I'll just tell you this was really challenging. It still is. And I think that is because standards are really important when you're doing something like this. The value of it and was collecting data so that you could illustrate apples to apples. What is going on? And I can't compare Spain and France and the US on the same map if I'm talking about different variables. And trying to understand, this is a pandemic, this is a global thing, how, what is going on around the world? What can we learn from other parts of the world? And this is actually impossible to really do accurately. And we have to spend a lot of effort trying to do it as best we can. And there's a lot of reasons for this, but these 4 families of reasons are the main ones. But all of them are because we just don't have standards in how this data should be made available. So one is that there's just massive instabilities and inconsistencies in how data is reported. So that is how it is made available in terms of what these web pages are looking like. Do they exist? Where are they hosted? What structure is the data available in? How is it reported? We all see these data dumps that happen in terms of cases and deaths that are just dropped in. And we all know that there wasn't 1 million cases in Turkey on one particular day, but that's what they said. And so we would get these kind of data artifacts that would completely distort the picture of the truth. And we're trying to tell this story of the epidemiology while you actually are dealing with this big difference between ground truth and what's being reported. And so part of this is why we built these anomaly detection systems, to try and catch those. And every time they happen, we work really closely by communicating with the public health agencies that are providing this information to try and get more information on what that data, when it really occurred. Can we get back distribution so we can smooth these curves out? And sometimes we can, and sometimes we can't. But what we never do is make assumptions ourselves. So if we can't, we put in the best data that's available from the source, and then that's what we report. But we never try to make our own assumptions on when something happened to make the curve look better. I think that that's all really important. And we know that the reported data is not ground truth, but I think that's a second academic exercise to be done. And so that is one of the reasons that the data quality, is noisy, it is ugly, but this is just what is being said. There's also very annoyingly discrepancies in what's being reported by authoritative sources. So this is not a US only problem, but it's an example that we have data coming from counties, we have data coming from states, we have data coming from the CDC, and they don't align for the same point location. So Harris County will say something about itself in Texas, and the state of Texas will say something different about Harris County because they report differently, they quantify things differently, they report at different frequencies. And this is a real problem. So we have this fusion logic to deal with these things, but it's very misleading, and it requires us to actually collect multiple sources of data for the same point location in the same point in time. Obviously, there's frequency issues in terms of both globally different, we're dealing with a pandemic. This is a 24/7 reporting cycle, which we really felt in those first few days and weeks, I'll say. But now there's different types of reporting and frequency issues in that states were reporting daily, and then they start reporting 5 days a week, and then 1, and then sometimes none. And then they realize the pandemic didn't go away, Florida. So then they'll come back and they'll start reporting again because they kind of got forced to, but then and we have to be really nimble to be able to respond to these changes because we're scraping websites and then all of a sudden it disappears and then it comes back. So that's been a real problem. And I think, again, these need to be standardized, and there need to be requirements on timeliness of reporting, accuracy of reporting, frequency of reporting. And then a huge problem is actually what is being reported. What are the parameters? What are the definitions of them? What's a probable case versus a confirmed case? What's a positive test? How do we count COVID deaths? And these are all issues. And when these are not standardized, and you have a very politicized kind of public health crisis, it really provides a lot of opportunity for people to question the accuracy of what they're seeing. And so this is something that part of it was out of our control because there was new technologies coming around in terms of what tests were available and how that could be counted and things. So we always did our best to basically align with the CDC guidance and guidelines at the time, but those changed too. So these are things that really need to be addressed, and we've been real advocates publicly about improving these kind of data infrastructure systems and data reporting systems so that we can actually have access to actionable data. And when I say actionable, it's because I don't want total number of cases in the state of California for a given week, because that's not going to help me understand what's going on. It's how many cases have happened on a daily basis in each county, or even, a finer spatial resolution. And then I think another interesting point is, why us? Why Hopkins? Why are we doing this job? There's a lot of reasons for, and maybe for, why we shouldn't have done this, but there's a few that really just personally stand out to me that I think are important to think about, because they're important for everyone and they're important for other future situations that we are inevitably going to be in. So for those of you that think when COVID is done, which might be, COVID 7 or 9 or whatever it is next, there's going to be a bird flu, and there's going to be another one. And so these are hopefully things that we can take away and learn from. And one of the things is that I think maybe most important is we acted early. We recognize the value of this kind of information and the need for it to be accessible, and, provided in a simple, intuitive way. And so we were on it, and we did it in the first kind of days or weeks of this event. And I mean, it really wasn't available. For instance, like, these are my colleagues and I love them, but like the CDC's tracking web pages weren't up and running for months, close to a year later, in the quality that they really needed to be. So I think that the fact that this kind of data is open and transparent really early is critical. We were really lucky in that we were doing this in a very supportive environment. So from the earliest days, weeks when we needed it, we had support from this institution, so that as these needs and demands grew exponentially, we were able to continue them uninterrupted. And so there really needs to be similar kinds of funding mechanisms from states and government institutes and science agencies to support this kind of stuff quickly at the start, which is, quick is not a great word in government and bureaucratic institutes. And so that is a little bit of a problem. And, it was hours and days that really mattered at the start of this. We also, like I mentioned before, we're a bunch of technical people. We had the technical skills that we needed to do this. Like I said, this was software designers and computer scientists, data scientists, and engineers that ran this effort. And so I think these are clearly skill sets that need to be embedded into public health agencies ASAP if they aren't already. And the last thing is really hard to quantify, but it was really important, especially again early, is we were a private institution, a private group doing this voluntarily. We could do whatever we wanted. We tried really hard to do a good job at it, but there was no bureaucratic approval process to do anything a certain way. We could just make executive decisions on what to do. And that was necessary because we were working in this incredibly messy, noisy environment. And we did definitely make mistakes, and we would learn from those, and we would try and be open about explaining what happened and why. But I think that this enabled us to do something, and I think acting was better than not acting at the time. Okay, for real, how am I doing on timing? Should I? Okay, 15? Okay, thanks. I'll talk for like 2 minutes about some of the stuff we've been doing with the data, because I think it's really cool. And then I'll just take questions and we can talk about anything that's of more interest to this group. I don't know everyone's background, so I don't really know what's going to be the most interesting to talk about. But like I said, I lead a research team that really likes to use data. So we started off collecting it so we could use it. We got a little distracting with the collecting, but then we did get back into using it pretty quickly. And since spring really of 2020, we've been at least focused with half of our time on doing different types of analyses. So I was just going to mention a few of them because I think they're trying to address really important questions about COVID that we also can learn about other types of public health crises and actually beyond that. So I mentioned these already early on. We were looking at what was going to happen, trying to do long-term, broad, global predictions of where COVID was going to go. Then we got really into complementing our data with other large data sets. And we focused a lot in spring of 2020 at trying to understand the relationship between COVID and mobility patterns, because this was during the time of all of these stay-at-home orders. We had this very disaggregate, individual level cell phone data that we could use to track how aggregate kind of population level movements were changing over time, and started looking into that relationship with COVID. You can see these crazy drop-offs where people stop moving around. And no one's going to understand these plots right now, which is fine. The main thing that we found was that in the spring, there was a very strong relationship between what we thought, was representative of social distancing and mobility patterns, and reducing COVID transmission, which was fine, really obvious. Don't really need to do a study or write a paper about that. What we found that was more interesting, I thought, which was kind of an accidental finding, was that when we looked at how people's behavior changed in terms of when they stopped moving around and visiting certain places, it always happened before there was a policy in place locally that forced them to do so. And I think that really said people were making their own informed decisions based on information that they had, not because they were forced to, which really kind of supports the need and value of making this kind of information public. So that was the accidental finding. That was definitely, I think, the most valuable thing. The other thing I don't have on here that I will follow up is that we did this work and then everyone was like, great, this is so important. We should all incorporate cell phone data into mathematical models for forecasting infectious diseases. And then what we did is we continued to follow this relationship. And we found that in the last couple of years, that was the only window when it had any relationship, which I can explain for a lot of other reasons that I don't have time for right now. But what happened is we basically found that relationship completely dissipated. Other things dominated. And so we wrote another paper that was like, be careful, please don't over rely on these kind of data sets, because there's a lot of other important things and there's confounding factors, and that relationship does not hold and it should not be used to calibrate models. So it was just another example of how science changed and how we learned over the course of the pandemic, which happened in a lot of other different applications of this, but was a thing that was often also used and criticized by people that were upset with policymaking and decisions because it was changing, but that's how science goes. We have been part of a lot of teams that contribute forecast models. So we forecast every week how many new cases and deaths we think there's going to be in the next 1, 2, 3, 4 weeks. And we send these to the CDC and they go into these ensemble modeling tools to try and help guide policy at the national and state level. And then we've also looked at so that's kind of at these really high spatial levels, national levels. We've also done work at very local levels. For instance, we worked with New Orleans, the city of New Orleans early on, when they were trying to help plan opening and closing and doing some risk assessment work for them. And then these are some interests that I was really involved in before COVID that I still am. Most of my work is central around the role of humans and how I think as a species, we don't really make the best decisions a lot, and trying to understand why people act the way they do, what drives their decision making, especially when it's bad, how people perceive risk, what impacts, their beliefs. And so we were looking a lot at vaccine hesitancy for childhood vaccines, MMR, and now we're looking really closely at similar questions around what drives vaccine hesitancy for COVID, so we can understand where we should be, how we should be better informing people for this kind of public health decision. And we looked at relationships between vaccine rates and COVID case incidence and mortality rates, and then disassociating those by all sorts of things like demographics and income and political affiliations. And I found all sorts of clear, strong relationships and inequities around the US, looking at this at a county level, where there's clear groups that are disproportionately disadvantaged or clearly make different types of decisions. And so this is a long line of research that we're currently pursuing. And then we're also doing a lot of retrospective analysis. And this is really fun because this is with groups across all sorts of, with different expertise. So I think COVID has been driven by human behavioral choices more so than the virus itself. And I'm convinced we can show that with modeling. And so we're looking at trying to understand and quantify the role of all sorts of different risk factors that drive COVID, from everything from the role of climate, whether direct or indirect, because it affects behavior, to policies, to compliance with policies, to the properties of the viral underlying immunity, behavior, mobility, all of these kind of things. And I'll just say it's really complicated and there is no one answer, and everything changes over space and over time. And so this is gonna keep us busy for a little while. So that's another big area that in general with most infectious diseases is the question that I'm most typically interested in, is what drives things to, you know, happen the way that they do it, really. And then what's next? So I don't want to work on COVID forever. Nobody wants to hear about COVID anymore. We're going to keep doing that for a bit because we want to make sure we learn everything we can from it. But there's a lot of other problems that really need data-driven decision-making. And so we have a big new effort that's joint with my center and Beth's group at the Center for Civic Impact that's looking at taking kind of what we learned in these infrastructures we built that and the philosophies behind them to try and help solve other types of problems that cities face around the world. And this is everything from, you know, looking at issues around climate change and energy consumption behavior and broadband access to public health and decision-making. My real pet project in this is understanding and quantifying the role of misinformation in different locales, information consumption patterns, and what impact that has. And so we're looking a lot at that right now in the group, as well as all that other stuff I talked about and some other things. So this is the team when we were together back before COVID, and then my fine artwork with the new members of the team that I haven't gotten to update our photo. And I want to recognize and acknowledge some of the different resource support that we've had. This is foundations, industry, government, and then some of the recognition that we've gotten for this work as well. So with whatever time we have left, I'll take questions. Yeah, this is a great meme, right? Someone circulated this to me and I sent it right to Ron. Thanks. I just go with it, pretend it's my classroom.
Hi, Gary Levine, engineer from 1977. I'm also a physician, so first, thank you. You've done for the 21st century what Abel Warren did around 1902. But my question—
I don't think the mic's on. I could hand this one, or I don't know. You just have to talk really closely to it.
Okay, Gary Levine, 1977, I'm an electrical engineer. Ralph Casaraggio was my advisor. And he retired in July of 2020. So whether you knew him or not. But my question revolves around, how did you clean up the data? How did you make sense out of all of this? And I credit you for pulling this all together in a timely fashion, in a very chaotic, and in a very forward-thinking fashion that I think only a university can do, with good financial support from a lot of different sources.
I have 6 minutes left, so there's no way I can explain that. We clean up different data streams differently. It depends. So the one thing I can say is I can't say that the data accurately represents what really happened with COVID. What I can say is the data accurately represents what is reported about what happened with COVID. And those are two very different things. So that we can manage, and we do our best to always make sure that and we spend a lot of time validating what, is coming in from the scraper versus what it says on the source and how that propagates through and making sure those align so that we're accurately transferring that knowledge. Because we're really just centralizing and aggregating information that's coming from a lot of places because there's value in having that in one place. In terms of what actually happened, oh, yeah. I think your phone, yeah. That's a different effort that we have going on. Is echoing a little bit, huh? Yeah, I think is it that one? We are doing a lot of work with an archival process, actually, going back, trying to, I'm not, maybe it's on here. I can stop sharing this. I can also turn this off and just yell. Do you want me to turn this off? I'll just yell. Choose this. But yeah, we actually have a effort going on now trying to go back and do data collection, but then looking at, as local places have gone back and said, okay, well, here's what we reported, but here's retrospectively what we think really happened, trying to collect those as well. And then trying to do our best to try to, map reported back to real ground truth. But it's every country, state, and county is reported differently. Some reported by date of death, some reported by date of report, some report cases by symptom onset, some by when the test was done. So we look into every source to figure out what they're reporting and try and always pick the variable to make it apples to apples, but it's impossible to be doing it perfectly because it's sometimes they just only provide one thing and that's not the same that someone else provides. So.
Two very quick questions. It was an absolutely fantastic talk. Thank you very much for doing that. The first question is, you've spent an amazing amount of time putting together this framework. How adaptable do you think it's going to be for the next pandemic, wherever it may come from and whatever it might be, in terms of how rapidly you'd be able to respond to that? And the second question is, given the amount of data that you have from all over the world, do you have any way of being able to determine whether the data you're getting from a particular country may be subject to manipulation for political motives?
Those aren't quick questions. The answer to the first one is unfortunately not nearly as adaptable as I would like. Our scrapers are customized for each website, and because there isn't a standardized reporting system in place that just says, here's the format and the framework and the way that it's provided, we can't just switch columns from COVID to dengue, which is what it should be. But lots of things that we've learned in the infrastructure that pulls it together and anomaly detection and logic, those things could be reused. But it's not just going to directly swap, because I would love to see this for just standing annual influenza, right? The second question is not part of this data collection effort. It's a secondary thing. And there's a lot of things that I personally do that is interesting, where you could compare things like what's reported to excess deaths for a country over time, because that data is available and you can start to get a sense of it. And we've looked at that, and a lot of people have looked at that, and you can see some places are really good and they just seem to be explaining all new deaths map to the number of COVID cases. And some places there's 120% gap, and you can clearly see that something's been going that's not reported. But it's just something where the data can be used to guide one of those kind of analyses, but it doesn't itself say anything.
So many amazing things to congratulate you on, but one aspect that happened here is that you were able to reach right out. And I'm curious, about some of the backroom conversations. Did you have to go, right to the president of the university to put your stuff out on the web, without saying that there was any IP that needed to be protected or whatever?
So I just started doing it all on my startup funds because I was new to Hopkins, and Ron reached out to me and was amazing and just asked how he could support. and then has been supportive from the start. IP was always, for me, this was not something where IP and monetizing it was a focus. We went through some of that, but what happened was we did it because I said this data can never be sold. So it was, yeah. And I am happy to hang out for a few minutes when this is officially done, if anyone wanted to ask more questions.
No, I also wanted to really appreciate this talk. 2 hours ago in this room, we were talking about shrooms, and I didn't think that I would really want to hear more about COVID, but you made it so interesting, and I would love to hear another talk on all of those questions. And so I really appreciate that. And, I was just thinking, from the beginning, I've been one of those people who monitored the charts of all 50 states before lunch every day. And, and I'm just thinking that the way the data was represented was so different. Like Harford County did it differently, state of Maryland different, than this JHU database was different. Finally, like there were some much prettier charts on like New York Times and Washington Post. But, if I just something would come in the news and I'd say, oh, what's going on in Douglas County, Colorado? And then I go and their charts are really weird. And, given how important, and you have also emphasized how important it is for the public to get this accurate information and to understand it and make decisions on the basis of it. Now, after all of this experience, I just wonder if anybody has gone and studied the data representation and compared it, how useful it was by county or by state or something like that, so that is there any chance that it could be maybe more uniform and better in the future?
We do it all the time. So we regularly compare in the back end what we're saying versus what New York Times is saying versus what CDC is saying versus what the states say versus CDC, because we scrape multiple websites. Even
I'm not talking about the data accuracy. I'm talking about the visual representation.
Oh,
and
just how it's
understandable it
visualized.
is.
Oh, yeah, data like
reader.
visualization
Yeah,
science and graphicacy and all of that. I've honestly been putting a lot more of my time into focusing on the data, but I 100% agree in terms of the communication of this, that is a big need. And there's a lot of work that's gone into it. And all of the CRC stuff, we do a lot of that. We do work really closely. We have so many iterations of the visualizations before they go through, trying to do our best to provide them in a way that's going to be informative and intuitive and not misleading. I think it's something that we'll continue to study afterwards as well. And I agree. I love the New York Times stuff, and we communicate with them. And I think there's a lot of people that have been trying different things and copycatting, but it's an open question.
We'll take this question and then I'll do one more. And then Lauren, you mentioned you could stay around for
yeah,
a little
sure.
bit. Okay.
Thank you. Hi, Professor Gardner. My name's Catherine, and it's really great to see you again since March of 2020 and following your work for the past 2 years. And my question is, in addition to the behavior change finding, what were other unexpected outcomes when you were integrating socio-demographic data? And what are you hopeful for in your future collaborations with
So
public health?
in addition to what?
In addition to like the behavior change finding that you had when you were pulling cell phone data, what were the unexpected outcomes for integrating socio-demographic data for?
I don't know if they were unexpected, but the obvious
Sure.
outcome is just the massive inequities, right, that are there. And I think that's the big focus. And it's two things. One is the focus on just making sure that those are clearly quantified and provided and communicated. So we went through a phase where at one point, no states were providing demographic breakdowns of cases and deaths. So we did a lot of advocacy to highlight that that was missing. And then states started providing that. So the first step is actually just identifying the missing disaggregation of the data that needs to be there to understand problems, because it was a while before we really knew who the most affected groups were, right? Like who were the, really like disproportionately affected groups. And then the second is then addressing that and trying to figure out how to help with that, how to target policy and resources and things. So
Thanks. We'll take this last question and I'll pass it to you, sir.
Thank you. I'm Alan Wiseman from the class of 1965.
Ah, you beat him.
So it seems to me in these many years since, you've done more for Johns Hopkins worldwide than any other institution here, which is phenomenal.
Again, not me.
You and
but
your
yeah.
team. Now, my question has a simple answer. What kind of resources? Was it $100 million? What did it take to do what you've accomplished?
Should I pull like an Austin Powers thing here right now, or yeah? I don't have a number, but I will take $100 million if you're offering, because we have a lot of more expensive problems.
A good question. Well, I'll just wrap up and just say a huge thank you to Dr. Gardner for your talk today and your team and research. And thank you all for coming.
Thank you.